We now have a combined session of 4 presentations. I'd request the chairpersons to please stay on. May I request Dr. P.P. Mohanan from Thrissur, Kerala, Dr. J.S.S. Ruiz from Spain, Dr. Apurv Mittal from Delhi, and Dr. Dhara Sanghvi from Vadodara to please step onto the dais for a felicitation ceremony, and we'll be clubbing 2 sections together. Dr. P.P. Mohanan will have the first set of honors.
Yeah, he's here.
Okay. I request Dr. J.S.S. Ruiz, Dr. Apurv Mittal. Dr. Mittal, if you could please step onto the dais. And along with him, Dr. Dhara Sanghvi.
Nice pleasure
Sanghvi,
please come and join us here. Yeah. Apur,
Sanghvi, if you are in. Yeah, please
come here. Who is the 4th one?
Yeah, Dr. Dhara Sanghvi. She's just joining.
Dr. Dhara, please come. I'll request, please give me a token of appreciation for all of them. Why we are doing this? Actually, I have to go for some important meeting, and Krishnam Raju also has to leave. So we thought we'll just try to give a token of appreciation before they start their presentation. We have 4 important speakers. One guy has come all the way from Spain, and he's going to talk on a very important subject, the brain ischemia syndrome. He has used a different language to express this, but that's a very, very important thing which is coming up. So he's come all the way in a tremendous pioneering experience in the protocols. So we'll listen to him. And the second person we have is Dr. Mohanan, coming all the way from Kochi, and the future of CSI, and he's the organizing secretary of the next CSI conference. And we have Apurv Mittal, who is the interventional cardiologist chief in our hospital. And we have with us Dr. Dhara Sanghvi. She's come all the way to speak on a new promising molecule, azilsartan, 10 and gliptin. And we have talking on a promising molecule, azilsartan by Apurv. So I'll request Satish and Poonam to give a token of appreciation first to our learned eminent faculty speaker coming from abroad, Spain, Dr. Luis. What's the tradition in India? I hope you will excuse us.
I know.
Thank you.
This is for you. Okay. Thank you so much. And this is for
just a token
for you. Okay.
From
Mohanan.
Oh,
Mohanan, thank you.
Mohanan missed the inaugural function, and I think our chief guest could not give him the recognition. So I'll request Krishnam Raju and Kapoor, please come forward. And Poonam, of course, to give a token of appreciation.
Ladies and gentlemen, Dr. Mohanan is conferred with the award of Outstanding Contribution in Cardiology in the World.
Both. Leave it here. 2 more eminent speakers here. We have Dr. Apurv Mittal, who is the Chief of International Cardiology in our hospital, and a tremendous experience in escorts. This is also for you. So many things.
It deserves it.
Next one. Apurv, please come here. Apurv Mittal is going to give a very nice talk on a promising molecule, azilsartan, powerful molecule, the future. Apurv. We have Dhara Sanghvi talking again of a new molecule, teneligliptin. Can I have a token of appreciation for her, please? Yeah. Thank you very much. With this, we start this
We'll move on to
proceedings
these sessions. Thank you very much, Dr. Chopra. Ladies and gentlemen, I'd request Drs. S.C. Manchanda, I.P.S. Kalra, H.K. Reddy, Pavan Sharma, and Rakesh Sharma to please chair the proceedings of this combined session. We move on with the first leg, that is featuring, we'll have the first leg of the presentations that features for the next 14 minutes, Dr. P.P. Mohanan. He is the Senior Consultant and Head of Cardiology and Intervention Cardiology at the Westfort High-Tech Super Specialty Hospital from Thrissur in Kerala. And he'll be speaking on antiplatelet therapy in acute coronary syndromes, critical issues. Dr. Mohanan, please, to help you be on time, we have a timer straight across. Thank you.
I religiously come to Mount Habu to attend these meetings, and
My job today is to speak a little bit about the antiplatelet therapy in acute coronary syndrome. Over the years, possibly one of the most important contributions in cardiology was the contribution by the antithrombotics as a group, which tremendously reduced the mortality, especially in the acute coronary syndrome setup. And first amongst there was aspirin. Possibly we got it right from the Moses days, and we have empty number of data to support aspirin is an important agent in secondary prevention. Huge number of data and definite guidelines about the dosage, about the continuation of it. No confusions about aspirin as an antiplatelet drug in setting of acute coronary syndrome. 2016 also denoted the 20th year of usage of dual antiplatelet therapy. We started it with maybe ticlopidin sometime in the late 90s. And then of course, clopidogrel was there for all of us to use for a quite number of time. This was the beginning of it. Then also we realized about some of the inadequacies of clopidogrel, the resistance, the drug interaction, the increasing incidence of stent thrombosis. So that augured the genesis of newer, more potent, more reliable platelet inhibiting agents, even some of them reversible P2Y12 inhibitors. So much so we had quite a lot of drugs. Clopidogrel, prasugrel, and Ticagrelor. There was some time, at one time, people was hesitant to know which one is the best drug, a combination for us to use in the setting of acute coronary syndrome. There was also some information about the newest of that molecule at that time of Ticagrelor when compared to the other P2Y12 agents, reducing the overall mortality. But the confusions are over. We have now strict algorithms, very, very confirmed guidelines from every major cardiovascular societies, which tell us which are the dual antiplatelet drugs that we have to use in the setting of SCS, whether you manage it medically, whether you manage it with invasively. So that is very well clear. Well, something which I want possibly to focus today is about the few things like the issues like now. Basically, one has to balance between the peri-procedural complications and the clinical benefits. Clinical benefit in the terms of reduction in the mortality, reduction in the disability. But if you look at the right corner, you'll also see the critical issues are the cost, the ease of its usability, maybe more importantly, the duration of the dual antiplatelet therapy. We have been hearing a host of informations about somebody uses it for 3 months, 1 month, 3 months, 12 months, 3 years. There have been quite a lot of arguments put forward to the shorter duration of DAPT versus the longer duration of the DAPT. And of course, finally, about the importance of bleeding. Again, you have to do a balancing act between whenever you use antithrombotics, anticoagulant or antiplatelet, you have to balance it between ischemia and bleeding. This was again some of the data. I don't want to bore you with a lot of data on the DAPT. We have again this year showed the publication of the guidelines by the ACC/AHA on what should be the ideal duration. This may not be the last word. I should caution you. This clearly says now whenever we are using in the setting of an ACS, ideally a dual antiplatelet drug should be continued for 1 year. Then you may think otherwise. If you think that this gentleman has a higher chance of bleeding, then stop dual antiplatelet drug and continue aspirin. But if you think that his ischemic risk is high and his bleeding risks are low, then definitely we can continue the dual antiplatelet drugs for a longer time. Just like we have heard about the scoring system, we have again a DAPT scoring system. No, that slide is missing. Anyway, we have a scoring system which be based on the age, then based on the smoking, the history of smoking, diabetes, whether he has a prior MI, again the size of the stent, that the width of the stent we are using. So based on that, we can assess that particular patient's risk of bleeding and risk of ischemia and individualize whether to decide to continue the dual antiplatelet drugs long term. Now this is something which I have just mentioned. The current guidelines are definite that if you are using in this setting of ACS, we have to continue DAPT for a period of minimum of 1 year. And class 2 indication, class 2A indication is one may assess individually the risk of ischemia versus bleeding and decide to continue the dual antiplatelet drug longer term. So more and more we are trying to sort of individualize the therapy of antiplatelet drug. The second important point I just want to touch upon is the issue of bleeding. As I said earlier, whenever you have more potent drugs, naturally the chances of bleeding also increases. Again, this is elementary question. Does bleeding influences the prognosis of ACS patient? Definitely yes. This was the data from the Grace, one of the largest European registries, which has shown undoubtedly that if you have excess bleeding, the prognosis of ACS patients are dismal. Then what about if there is a bleeding? Why don't we tackle it by blood transfusion? I will come to that in a minute. Before that, there are some vulnerable population who have a proclivity to develop bleeding, like the elderly, the CKD, the anemia. These are the groups of patients. This was the outcome. Now, I have just shown earlier one of the data. This is another data. What about transfusion? Transfusion, though it may bring up the patient's hemoglobin, it ultimately decreases the 30-day survival in those ACS patients who have been transfused by us. Not only the 30-day survival, even you look at the 1-year survival rate. Those who have received transfusion during the period of acute coronary syndrome because of some bleeding complication has a worse mortality at the end of 1 year. So bleeding becomes one of the very, very important issues, critical issues in the usage of antiplatelet drug. And as I said earlier, age, female gender, CKD, the procedure time, of course the sheath time are very, very important. Now we have more information also coming up about the importance of diabetes and anemia are also now be considered as very important risk factors for the bleeding amongst the ACS patients. So as I said earlier, one has to be critically analyzing, balancing the safety on one hand and efficacy on the other hand. And whenever you use, whether you use antiplatelet drug, whether you use anticoagulants, these has to be kept in mind when we use more potent drugs. So summarizing, ladies and gentlemen, anticoagulants, antiplatelets, especially antiplatelets are the cornerstone of therapy of acute coronary syndrome. The guidelines has been very clear on the choice of drugs. They are also partly clear on the duration of DAPT. Of course, the duration may need more data to tell us exactly. See, we have the newer data on Ticagrelor, which says, the Pegasus strata says that you can continue the DAPT for 3 years. But that possibly may need more information before we cement that and say that, well, we can continue DAPT for long. The bleeding has to be assessed individually, and the recently found scores like the DAPT scores, which was processed after the famed DAPT trial, will help us clinicians and cardiologists and physicians to individualize patient with ACS and your decision on antiplatelet drug. Thank you for your kind attention.
Thank you very much. Great presentation. We have time for one question, at least one question. Anybody have a question?
Thank you very much, Dr. Mohanan. Ladies and gentlemen, as Dr. Mohanan has to leave, probably we'll take one question from the chairman and then he'll depart. Please go ahead.
Please.
Anybody have a question? Anybody? Anybody from the audience?
I'm Professor Sainani from Mumbai. Excellent lecture, sir. I've heard a lot of lectures, antiplatelet and this, but I'm still confused about the duration of antiplatelet therapy in a conventional ischemic heart disease case diagnosed on medical therapy, in a case having angioplasty and stent, in a case having a bypass surgery. Because what I feel find in my city, Mumbai, there are quite a number of cardiothoracic surgeons who say, take it for life. Angioplasty, people, 1 year strict, then you take it for life. Some say you stop. And the persons which I treat, just medical therapy, I've been giving them small dose of aspirin and I take them for life. Am I right or not? So I want to clarify this, though there are guidelines that it should not be. I usually don't believe many guidelines, because guidelines, and here we are treating our Indian patients, and guidelines come from America, Europe, and all that. So please clarify my doubts.
I think till we generate our own guidelines, we have to look into whatever is available for us. For example, the 2016 ACC-AHA was very particular on various issues on continuation of DAPT. I do agree that the paucity of the Indian data and the Indian guideline is an issue, but I think in matters of ACS, I think we follow whatever is available.
The other thing what I want to mention is about DAPT. It has been shown and published that if you use DAPT for more than 3 years, then the risk of mortality because of non-cardiac causes, especially cancer, goes up. So that is why in our practice in US, we try to use it for 1.5 years, 1 year. Some people, we use it only for 6 months. So we never go more than 2 years, actually.
It's more into an individualization, and that has helped us a lot.
Fine. Thank you. Thank you very much, Dr. Mohanan. We look forward to seeing you again on academic platforms. Ladies and gentlemen, that was Dr. P.P. Mohanan from Trichy. As he has got a flight to catch, he would like to take leave.